Well, good evening, everyone, and welcome to Your New Passion Awaits, top specialty areas for the family nurse practitioner. Over the course of the next hour, what Dr. Miller and I are going to do is talk and dialogue about information to provide you information on the fastest growing specialties for not only family nurse practitioners, but also adult gerontology nurse practitioners as well. We'll also talk about some tips in terms of how do you switch from one focus area to the next, acing that certification, that elusive certification exam, and the pros and cons of practicing in each discipline. What we're also planning to do tonight is to just talk a little bit about legal issues as they pertain to scope of practice as well. You have a question and answer box for most of you, it's going to be down on the bottom of your Zoom. Please feel free to ask us questions. I will watch that question and answer box and we will talk as we go through. You also have a chat box where our moderator, Dina, is watching. If you have any technical questions or questions about this program, certainly go ahead and text or send in the chat box for Dina and in the question and answer box for myself and Dr. Miller. Dr. Miller, can you introduce yourself? And then I'll talk a little bit about myself and we'll kick this program off tonight.
I can introduce myself. So my name is Sally Miller. I've been with Fitzgerald Health this is my 24th year. I've been a nurse practitioner for 31 years and a faculty member for 29 of them. So when it comes to things like various certifications and the pros and the cons and all sorts of implications, I have a little bit to offer on that topic of convo. As you would remember, Dr. Wright, once upon a time, you didn't have to go back to school to get another certification. Back in the old days when we took notes, and chiseled on tablets and stuff like that, you could get another certification if you just had 1,500 practice hours in that specialty. So as a result, in the early years, I accumulated specialties pretty quickly. I started off as an adult primary care NP because that was just the way we started off. And then over the years, became certified as an acute care nurse practitioner, which then in 2008 became an adult gerontology primary care or an adult gerontology acute care NP. Along the way, I picked up the pediatric piece into the family nurse practitioner thing, and most recently a psych mental health certification. So I certainly have the whole spectrum to talk to people from. But even aside from that, as a faculty member there is definitely more of a trend toward dual certification or multiple certification. And there are things that you want to be on the lookout for when you go back to school for it. And not just the practice piece, but school as well. And then the other thing is scope of practice and legal ramifications in each state of practicing in a different specialty. So we have a lot to talk about tonight, and hopefully I have a little bit of everything to contribute.
As I tell you, every time I see you, you're my role model. And so I can't compete with this. I am Dr. Wendy Wright. I am an adult and family nurse practitioner. Started my career 32 years ago as an adult nurse practitioner, honestly having zero desire whatsoever to ever treat children or pregnant women. But when I relocated out of Boston, I found that there were really no internal med jobs. And so in 1995, I graduated with a postmaster's in family practice and have been working in family practice since that time. I've served numerous roles as faculty through a number of different programs. And so it's truly my pleasure to be here with you tonight. Today, I own a family practice where I have 11 nurse practitioners, soon to be 13, that work alongside me, where we take care of 6,500 primary care patients. So, all right, I think we should just kick this off, Sally, and let's talk a little bit about why would anyone go back and get additional certifications? I mean, what's the purpose, really?
I think it's more important now than it ever was before. 20 plus years ago, an adult nurse practitioner or a family nurse practitioner could almost work in any setting and make a case for that. I mean, like you, I never had any desire to treat children. Not that I don't like them, I had one, I was pretty
Me
nice to it.
too.
I
Yep.
fed it, watered it, it grew up, it's still with us. But I didn't want to treat children because I was afraid of them. But it was just a matter back then of even getting an interview in a rural state, even for a position that did not see children, just getting your foot in the door. Like that was then. But once you had that primary care NP, you could pretty much work anywhere. It wasn't an issue legally. It wasn't a scope of practice thing. Employers weren't that interested in it. It's only been probably for sure in the last 10 years and maybe the last 15 years that specialty settings and employers are much more cognizant of the differences among certifications as well as state nurse practice acts. So I think probably the very first piece of that discussion for anyone who is considering practicing in an area other than the primary care practice for which they are certified is to look at the law in your state and see if your state restricts you. I used to practice in New Jersey, and the Nurse Practice Act there has not changed. It's the same thing it was 30 years ago. An NP is an NP is an NP. If you're an NP, you can see any patient, and the onus of responsibility is on you. If you ever get sued or have to defend your practice in any way, the onus is on you to demonstrate that you have the appropriate experience, qualifications, et cetera. Then I moved to Nevada and find that Nevada was very strict about the particular specialty in which you are certified. In Nevada, if you are a family nurse practitioner or an adult gerontological primary care nurse practitioner, you are not permitted legally to practice in a mental health care setting. Or well, the mental health is the one that comes immediately to mind. You just can't do it. And I think I don't know if I mentioned or not that for 3 years I was the APR and investigator with the Board of Nursing here in Nevada, and I saw one nurse practitioner not just have a reprimand on her license, which is there for the rest of your professional career, that is there every time someone queries your license. And another MP have both a reprimand and lose her job because she was practicing in a psychiatric practice and was a family nurse practitioner. It was out of scope. So
I
look at your
think
law
I agree
first.
with you 100%. And one of the things I say every day when I'm speaking is you really want to make sure that your certification aligns with the practice setting in which you're in. Now, clearly, there are some specialties. I think of maybe correctional medicine. Maybe there's something that exists. I don't think there is, but I think that for me, when I first became an NP and I came into New Hampshire, I applied for privileges at a hospital in order to round on patients in that hospital. Now, my scope of practice, like yours, really hasn't changed. It says you may perform that for which you are educationally and experientially trained. Well, I rounded with a physician for over a year. I learned hospital medicine through that physician and felt like I could defend myself should there ever be a question. But it was so interesting because this was back in the early 90s or mid 90s, around 95. I remember the hospital saying, "We have no idea what to do with you." And I didn't know what to do with me either. But what they did at that point was they gave me unencumbered privileges. I could round in the ICU, I could round on OB, I could round wherever I could defend that I medically, legally, was prepared to do that. That's a very different ball of wax now. Now I'm credentialed at another hospital, but my privileges are very, very limited. And they're limited because I'm a family NP who has not gone to an acute care program. And I think that you and I were talking a little bit in preparation for this program tonight. I'm seeing hospitals across the nation say, if you're going to work as a hospitalist, you need to be hospital trained, acute adult gerontology type of focus. Are you seeing something similar as well?
Oh, definitely. I mean, here it's really interesting here in Nevada where I practice now, because as we were talking about earlier, our state Nurse Practice Act does not single out adult gerontology acute care as a population focus. It's not recognized by the law as a population focus. So, who can practice in a hospital? Well, anyone that is certified to see adult or gerontological patients. And so from a law in the state perspective, a primary care NP can apply for privileges or work there as an employee, work for the service. But if there is ever an action for which that person is served with a complaint and a malpractice action ensues, well, then of course, one of the first things that the plaintiff's attorney is going to look at is, well, you're certified in primary care, but you're not certified in hospital care. So the hospitals now, it's not so much a law thing in my state, but it's about defending themselves against a malpractice action. Because if someone sues an NP who is working for a hospital, and the hospital is the bigger, the deeper pocket, then of course the interest is in the fact that the hospital should have known or should have ensured that they are providing care providers who are appropriately trained in that specialty. So the bottom line is the hospitals are requiring acute care certification to ensure that they are protected if there's ever an action.
And if any of you have ever heard me speak on medical malpractice defense, both Dr. Miller and I do a significant number of medical defense as well as some plaintiff work.
Mhm.
But some of you may have heard me talk about a case that I worked on out of Oklahoma. It was more than $150 million case. And I was hired on a scope of practice issue. The nurse practitioner was a family NP working in the emergency room. And so what they did during the course, the plaintiff actually got her transcript and held the transcript up to me and said, tell me which of these courses say emergency room. And my response was, none of them do. But in every primary care course are built in urgent issues. And so just because it doesn't say that this is acute issues, but that plaintiff actually sued the credentialing body for credentialing this nurse practitioner who's a family NP in an emergency room and alleged she should have been either an ER NP or an acute adult gerontology NP, which we know that acute is really designed to be inpatient, not in the ER. Have you seen any of that in the cases that you've worked on?
And I have, and Oklahoma is especially interesting because they have some really weird laws. I mean, they have some interesting laws. Even the semantics sometimes are very unusual in Oklahoma. Every state has its own thing. But I think the irony is you need to be an FNP before you can be an emergency nurse practitioner.
And that was my defense, is there was no pathway for this NP at the time that the case
Right.
happened to become an ER NP, because you have to be a family NP for 5 years in order to then sit for that certification exam. Now, we know that things are changing though, right? Because now there are emergency room nurse practitioners. And I know I have an opinion on this, but I want to ask you, are you concerned about people subspecializing so much as NPs? Because a physician is a physician is a physician. Now I know that they do, postdoctoral work, and they will do some fellowships and things, but do you worry about the more certifications we get or that are available, are we starting to make this area gray about what each of us can do?
I think I'm choosing my words carefully here because I am not known for my diplomacy, et cetera, et cetera. So sometimes I regurgitate what's on my mind without putting it perhaps in, framing it in the most hospitable language. But I think that the proliferation of certification can do us more harm than good in several ways. And I also think that, when you have, yes, you have a physician who is a cardiologist, but they went through years. I mean, they went through years of
Medical
specialty
school.
training, and they are still a physician and could
Correct.
still, in an emergency, deliver a baby or something like that. So I don't think that it's the same. I think there's really differences between physicians who are physicians and then specialize, and then NPs who specialize in a thing. But the more we start to tease out these specialties, the more rigid we have to be, well, what you can do and what you can't do. And well, because there's not good communication among the states. I mean, it's better, before we had a consensus model, before we even had a NOMF task force, we were talking about how both of us, when we went to school, there wasn't even a NOMF task force yet. There were no essentials of master's education. And so a lot of us, our transcripts don't say things like advanced pharmacology and advanced pathophysiology and advanced assessment, because that whole concept didn't exist yet, and we learned those things differently. But I think the desire to tease us out, it it makes for smaller numbers. Like, look at the acute care specialty. You might be a new RN, you're in your early 20s or even in your early 30s, and you love it, and that's your passion, and you want to be an NP, so you go to school to be an acute care NP. And then 10 years later, if you never hear another code 99, you don't ever want to see another intubation tray or vent or anything like that. Maybe you want to work in community health or out in a remote frontier rural area, and now you can't. You can't without going back to school again. I just think that's one of the dangers. The other is that when you start going back for multiple certifications, it really becomes closely scrutinized. What did you take that transfers versus what didn't? And, if you have this specialty and you take this specialty pharmacology, it doesn't meet your need in another setting. And oh, I don't know, the phrase divide and conquer, as you start teasing out these little things, it becomes easier
Right.
to have
I
trouble.
mean, I think it opens up a very interesting dialogue. At what point in rural America, when I'm treating a major depressive disorder that fails to respond to first line of therapy, and I add on a second generation antipsychotic, at what point is that patient supposed to go over to you when we know that there's lack of access to psychiatric care around America? And if someone's going to wait for 6 months, do I not treat them with a second generation antipsychotic for fear that it's outside my scope? This is where I think the dialogue really needs to happen. I don't know that people want to always have this dialogue because it doesn't serve some institutions well for having this dialogue. Do you have any thoughts on that?
No. Well, everybody has an opinion, and specialties will have their opinions and the generalists will have theirs. And I don't know. I just think, well, like I said, I always am very careful about what I say, because sometimes I blurt out something it's not exactly what I want to convey. And while I'm putting this together, by the way, for those of you that are listening, please feel free to chime in with questions anywhere along the way.
Please.
We're just having a conversation. So if you wait for one of us to stop talking, it'll probably never happen. So if you have questions, just plop them in there. I mean, there are definitely pros and cons to multiple specialty certification. And, some of the cons are, do you lock yourself in too early? What if you pick a career path in the first decade of your career? Who knows where you'll be 2 or 3 decades down the line? And are you shutting doors for yourself? On the flip side, just one argument for starting as a primary care or an FNP is that then from there, you do have so many options.
Right.
And if X number of years down the line, you decide you really do want to focus on the inpatient setting, or you really do want to focus in peds, or you want to focus anywhere for that matter, you certainly can go back for a second certification. And sometimes we don't really know where we want to be until life, you have different experiences and realize that one really grabs you. So I definitely think there is a role for specialty certification, but I don't know. I think if I had it to do again, I know that I would have started as an FNP, just because at you can do so many different things. You can work in a typical, suburban or urban, like for-profit practice, or you can work in a very rural practice, or you can work in any variety of outpatient specialty areas. You can do all of that and get your feet in the water. You get introduced to virtually everything. You might think that you want to be a psych NP until, as a family nurse practitioner, you have a couple years of trying to manage depression and anxiety under your belt, and then realize that's not for you at all. Whereas if you had gone into a psych NP program, well, you know,
And it's interesting to me because I have a colleague now who came out of school as a psych NP and asked me last year to write her a reference. She wants to go back and become a family NP because her thought is, I feel like I could do so much more than just treat the mental health piece, but I could actually treat some of the other issues. So I agree with you. For me, if I had it to do over again, I would have started as a family NP. And I guess if I were to summarize the last 20-ish minutes of our conversation, for me, what it means, what I would say is start out general. You can always become more specific. It's a little harder to become specific and then go out to be general, but make sure that where you're working, if you have the opportunity, matches your certification. If you're going to work in an inpatient psych facility, it probably behooves you to be a psych NP. I mean, at least to add that on. That's just my 2 cents. And there are so many programs out there now that allow you to just take those additional courses to be competent in med prescribing, etc. Any other comments on this first kind of 20 minutes of our conversation?
Oh yeah, I mean there's a ton of there are a ton of schools that have really developed to a fine art the opportunity for an NP who is already certified in one thing to come back and bridge to the other. There's different names for them, but it's really much more user friendly now for someone who has one specialty and wants to go back for another one to do it. And there really is a value in that. I mean, what I would say to people is if you're switching specialties, if and I'm just using the example of psych because I guess I'm so familiar with it. And I think it's the second biggest growing, I mean,
It
like
is
for the second biggest
big.
program. Yeah. If I mean, so I worked, I was family and acute for decades. And I had a fair amount of experience managing both outpatient and inpatients that had various psychiatric diagnoses and phenomena. And I mean, I thought I knew something about it. And I listen for all the experience and all that. I never, I really do remain very aware of the fact that I don't know a whole lot more than I do know. So I do pride myself on never getting cocky about any of it. I mean, I'm every day I still learn stuff, and I mean that very sincerely. But I did feel like, I mean, I had some experience with, like the typical things you encounter. Um, and then when I chose to go back and do a psych program, that's when I realized how little I knew. I mean, I really realized how little I knew. Just even, no, forget the psychotic disorders. I mean, a primary care MP should not be managing a psychotic disorder, period. You take my word for that one, you shouldn't. If that's what you want to work with, you really need to go back to school. But even things like, quote, depression and anxiety, most FMPs really no introduction to the fact that there are numerous anxiety disorders and they don't respond to the same things. They're not treated the same way. Some of them respond very well to certain meds, others do not at all. There's some anxiety disorders where the intervention is a therapist. No drug, there's no med for you. You need to go see a therapist. And you probably don't know it unless you go through some more specialized education and figuring that out. I can remember in primary care, I mean, there were so many times where I would see a patient and they would say they were depressed, and I would like do a PHQ-9 or something or some tool, and I checked it all off and they had the right score. And I was like, okay, you're depressed. And I put them on antidepressant and they don't get any better. So, of course, I thought it had to be them. It couldn't be me. It had to be the patient not taking the med the right way or something that, of course, it wasn't me. And then when I went back to do a mental health program, I realized what a PHQ, and I don't mean to pick on that tool, any tool. I realized what tools do and don't give you and what else you need to explore. And that just like with anxiety, there are numerous subtypes of depression and etiologies and approaches. And so if you're going to work in a psychiatric practice, chances are you're getting the patients that didn't respond to primary care interventions. You need to know a little bit more about it. So yes, I am the person that paid lots of money to go back and get a second psych NP. So I do feel a little protective of it in that way. But I mean, I've just learned how much I didn't know. And I really am I really do not support an FNP practicing in a psychiatric practice, no matter how much experience they think they have, just because I know the difference. I can bridge the two, and I've seen
Well, and I think
I've
you've
seen
also
different.
seen sequelae at the Board of Nursing as
Mhm.
a result of that as well.
Well, yeah,
Yes, and
from a
again, I
practical
don't think we're here to
application.
fear monger whatsoever, because the reality
Mhm.
is the vast majority of us, we pray, will never be subject to any of that issue. But I think it's having this open dialogue and talking about what are those consequences. Maybe we could transition now, unless there's anything else you want to share about that. Have we missed anything in our first part of the conversation?
We won't realize it till after it's over and we're talking
Yes.
about it another day,
True.
but I can't
I
think
feel
of
like you and
anything.
I are sitting at a restaurant
I
having
know.
a conversation. It's really fun. So the second thing I'd love us to talk about is how do you choose a school? And if you want to do these certifications, not all places are equal. And do you have any thoughts? I mean, I think you've done your education through a bunch of different programs.
Mhm.
Didn't stick with one. I stuck with one for my first 3 degrees, bachelor, master's, and postmasters, and then went to a different university for my doctorate. So, do you have any thoughts about that?
Yeah, both from a student perspective and a faculty perspective, actually, because I've probably taught at more institutions over the years than I've attended. And as programs proliferate and especially add-on, second certification programs develop, there is a desire to develop programs that are user-friendly to people and to only require of them what's necessary to to bridge with their original MP education and be certification eligible. So if you have, and again, we'll take the FNP or adult general MP example to psych, or it could be to acute or whatever. If you have that core, presumably if you finish school like after the year 2000, it's very likely that you have the 3 Ps, that you have those on your transcript. It will say patho, pharm, physical assessment. You will probably have an evidence-based course. You'll have a roles course. You'll have, all of like those things that need to be there. And you can carry them with you to your second degree, so your second cert, so that you don't have to take them again. But you really do want to make sure that if you pick a university or a college for a postmaster's program, they will do theoretically a gap analysis to ensure that what you bring with you, in addition to the program they will require of you, in the end makes you board eligible for the board that you want. But sometimes in their haste to get into a program and to be accepted and to start quickly, and maybe being cost conscious and trying to find a program that isn't as expensive, I've seen some students jump into a program that was maybe new in development and hadn't put this whole thing together well. And the bottom line is that the 3 Ps or the core they came in with didn't really meet the core as outlined by the accrediting institutions, the Collegiate Commission on Nursing Education, the requirements of the NOM task force. And so the student graduates the program and gets a certificate and says, yes, I am the postmaster's, whatever, peds, acute, psych, whatever. But
Health.
then when they go to apply for their boards, the board organizations, they go through all of that and need to, check off on their list. Well, this person, I don't ever see this course here. Or maybe, I've seen a circumstance where a neonatal NP went back to do a degree that wasn't neonatology. It was it was a postmaster's psych and something else. And the school accepted neonatal pathophysiology and considered that one of the 3 Ps. But so the student graduated, got a certificate, tried to register for boards, but the certifying organization said, well, this doesn't meet the criteria of the patho that's required. So now the student has to go back and remediate that somewhere. So I would be very aware of not just what the program requires of you, the sequence that it's in, but also how they evaluate your gap analysis, how they evaluate the courses you're bringing in. And if you have any questions about whether or not they would meet certification criteria, investigate it before starting.
Absolutely. Do you have any comments about a student who wants to do this? How would they find out if these schools are accredited? Because I have seen colleagues who have gone to programs thinking that they are accredited, only to find out at the very end that they are not, or that they didn't get reaccredited. And now these students are sitting out there with 3 years or 2 years of education that is not certifiable, can't get a certification. Do you have any thoughts about how that could happen? Or how they could,
Oh, I
yeah.
I know how I know how it can happen because schools, they're trying to build their, no disrespect to schools. I am a professor at one, but especially newer programs. I mean, they're trying to build their student base, so they're very encouraging of people coming in. But what prospective students can do, there's a couple of things. Every school of nursing that is accredited, there is an approved statement on the website. The primary accreditor of nurse practitioner programs, School of Nursing nurse practitioner programs, is the Collegiate Commission on Nursing Education, CCNE. CCNE is the certification arm of the American Association of Colleges of Nursing. Now, if this matters to anybody, pay attention because it gets very confusing because those letters A and C and N, they're all over the place in the world of nursing, nursing education, and nurse practitioner certification. We have the ANA, we have the ANCC, which is a certification arm of the ANA, we have the AANP, and the AANP-CB, which is the American Association of Nurse Practitioners and its certification board. Then we have the American Association of Colleges of Nursing, which is AACN. So AACN is the one I'm talking about here. AACN, the American Association of Colleges of Nursing, their credentialing arm, they credential schools of nursing, and that arm is called CCNE. And so you could go to the CCNE website, CCNE, if you just Google it, ccne.org or something like that, or Google AACN space CCNE. It will take you to the CCNE website and you can they have a list of accredited programs. You can search them out by state. You can look and see if it's accredited and you can see when their accreditation expires. So that's a real easy one. The other piece is that the CCNE has an approved statement that only CCNE accredited schools can put on their websites. So when you first roll into the website, somewhere in the corner, somewhere, there will be this approved statement that they're accredited by the CCNE. And that's the first thing I'd be looking for sure, is to make sure they're accredited. That's a start, but it's not the whole thing because I know CCNE accredited schools where some of these problems have arisen. So once you ensure that it's accredited, then, I mean, other things you can do, certainly the blogosphere. I mean, as much as us old people cringe at techno, in many ways, it's your friend. Get out there and look on blogs. Schools that are longer standing, if the programs, I mean, the best bet is to talk to someone who finished the program you're looking at and is board certified. That they graduated, they're board eligible
Absolutely.
and certified. Ask them. If you can't find anybody from the school you're looking at who has taken a board exam yet, there might be a reason for it. And then after that, the only other thing is I would say that any of you who are very focused in your initial certification, like PEDS, a pediatric NP, or a neonatal NP, or perhaps even a women's healthcare or a gender roles nurse practitioner, really ask the advisor at the school, and you can also call both certifying boards or email them, both ANCC and AACN, AA, let me back that up. Both ANCC and AANP both have people who will answer these questions for you, and you can straight up send them a copy of your transcript and ask them if that course would meet the requirement. Because if you have a pediatric pharmacology or a reproductive physiology course, and that's your pharm or your patho, it might not meet the need, and you can find that out from the certifying boards right off the bat.
When I'm talking to people about interviewing for jobs and finding jobs, I always say reach out to people who have worked for that facility before. Ask them what they were like. So to me, this feels like what you're saying. When I go onto LinkedIn, I see people you may know who went to this university. And so message them and say, was there any issue with the courses that you took in being able to sit for the boards? The other thing is, while these programs may look all great and they come with this nice price tag, not all programs are alike. And a lot of students and I don't know that it's necessarily, the expensive programs versus the
Mhm.
less expensive, but people have a hard time finding preceptorships and finding placements. And I think you need to factor some of that in, is how do we line up these placements? Because when you did your psych mental health program, you needed placements as well, correct?
Indeed, and thank goodness that I knew somebody that I could slide right into, because I mean it's hard. It's really hard everywhere. And when you look at CCNE accreditation criteria, one of the criterion to accredit schools of nursing and their NP programs specifically is that they have adequate resources to provide experiences for the students. And so theoretically, a school should provide for the student a preceptorship. Now, it might not be the one you want. If you live in one state and choose to attend a program across the country because it meets your need in other ways, and you can't find a preceptor in your home state, well, the school ostensibly should find one for you, but it might be out there. So it might mean, pick up and move and go. So yes, the school does have some responsibility, but providing the experience doesn't necessarily mean that it's going to meet your needs geographically or logistically or even your preferences and all of that kind of stuff. So yeah, the preceptor thing, that's a really tough one.
It is really opening Pandora's box, and I know it's beyond what we're here to talk about tonight.
Mhm.
Can we talk a little bit about, is there anything else we need to talk about in terms of programs, accreditation, preceptorships, anything else that comes to mind for
I
you?
don't know. I do want to make sure we don't leave anyone with the impression of a negative, because I don't want to do that at all. Because, like we said, as you grow and mature, your interests do change, and if you really want to practice somewhere else, it definitely is the appropriate thing to do, to go back, not just from a legal or malpractice perspective, but just to know what you're doing. If you were an ICU nurse in the year 2000 and then we're a family nurse practitioner for 25 years, you can't just roll back
My
into,
goodness, I say that
maybe if
every day.
you
That's
can't.
me. I was an ICU nurse.
Yeah.
I wouldn't even know where to begin with the drugs these days, right?
And even the vents, which used to be this big,
Right,
I
right,
remember being in a hospital, like, is that a ventilator? Is that
right,
little
right.
thing a vent? So yeah.
No, I agree with you. And I don't think we're being negative. I always feel like I'm just being a little bit of a realist, and just pointing out things that people need to think about as they're thinking about doing this. As an owner of a family nurse practitioner, family NP clinic, what I'm finding is that NPs may start with primary care, but they often go off and specialize. And so as we think about why is it, I mean, I ask these NPs, why are you leaving primary care? And the reality is they want a different quality of life. Sometimes specialty pays better. It often does. I know in New Hampshire, if you go back and you become a psych NP and you work in our state for either 2 or 3 years, all of your loans are forgiven.
Mm.
So, I mean, I think that and I have an NP now moving on to specialty in a facility so that she can get her loans all repaid. It's something that I, as a small practice, just can't offer. But I have a lot of NPs who say, I just want to focus on one thing. I feel like I would be really good at that one thing if that's what I was focusing on. Do you have any thoughts about that?
Yeah, I just think I think you don't really know until you get into the world. And I mean, I know when I first started this, years ago when I was young and ICU and code blue, blah blah blah. I thought I would do that forever. And
Me too.
then all of a sudden, and then when I went back to be an MP, I thought I want nothing to do with the genitalia. I had no interest in women's health. In fact, I managed to get all the way through school and never actually do a pap or a pelvic, because back then you could get away with it. Now you really can't. But then and then lo and behold, 5 years later, I was working in a correctional facility with a female housing unit. Guess how I spent every Wednesday? Vaginal whatever.
Well,
So
if
you
truth be
never know where it's
told,
going to take you. Huh?
if truth be told, I feel like you were also a healthcare provider for a place out in Las Vegas, right? With a lot
Yes.
of
Yeah,
clients.
yeah. That's right. The brothels. Yes. Prostitution is legal in some counties out here. And for a couple of years, we had the contract with the brothels because the law was written years ago when endocervical culture was the gold standard for GC and chlamydia. So even now, I believe all of the women who work in the brothels every week have to have an endocervical culture for GC and chlamydia. Oh yeah, for someone who said she would never ever do it, there was a time when I spent a whole lot of, so you just never know.
You just
You
never
just
know.
never
Probably
know.
the folks at Fitzgerald who put us together probably shouldn't put friends together, because I know a lot about you and you know a lot about me that we could regurgitate. So not always good. But I do think that, you just don't know where your career is going to go. And I think getting additional certifications truly can be very helpful from a financial perspective, from a life perspective, a quality of life. Kathy says, I love primary care. However, there's no work-life balance. If one is hired part-time to complete everything in primary care, one will work full-time hours. And Kathy, I hear you. I absolutely hear you. In fact, I was talking about that today, where I said that I love primary care and I will never leave it. But the reason I probably have survived for as long as I have as a primary care provider is I don't do it 4 days a week. And if I did, I probably would not have survived. I would have probably moved off to do other things, because labs are always there, portal messages, phone calls, everything. And then we take care of a lot that the specialists aren't taking care of. And they'll throw these folks back to us. So I agree with you. In our clinic, we do 35 hours of patient time and mandated 4-day work weeks. They have 5 hours for admin time, but I tell them all the time, there's no way you're going to get everything done in that 5 hours. And we only see 10 to 12 patients a day, but there's a lot of work in primary care. I'm not sure that there isn't a lot of work in other specialties as well, but
Mhm.
I think it's different.